Hi, I'm Dr. Jack Schaeffer, and we've been talking about the evolution of eye care, and of course Schaeffer Eye Center's new theme, Evolve Your Eyes. And part of that evolution is education of our patients. And today I'm going to do a whole lecture on the dry eye. Ocular Surface Disease is something we talk about in optometry as what it encompasses, but so many of you out there have dry eyes. So I'm going to take a little time today and I'm going to explain a comprehensive review for you of all about the dry eye. And it starts with all this. It starts with the eye exam. Because when you have a general eye exam, and most of you do through your eye insurance, whether it be VSP, IMED, a multitude of insurances, including Blue Cross Blue Shield, we have a basic comprehensive eye exam. I use two words there, basic and comprehensive, because we really cover just an overall of what the eye is like. At that point, we may discover that you have a dry eye. And you may ask, well, how would I know I have a dry eye? Number one, you'll have blurred vision sometimes when you blink. Number two, you may have a scratchy, burning feeling. Number three, you may not feel anything. We maybe just see a dry eye coming on. And it starts not just with your eye, it starts with everything. So when we do an eye examination and we move to the dry eye evaluation, the first thing we're going to do is find out what kind of medications are you on. What is your ocular history? What is your medical conditions? Do you have Sjogren's? Do you have rheumatoid arthritis? Did you just start taking hormones? Are you over 40 years of age? There are so many things that precipitate a dry eye in an individual, but it all starts with that, and that's how we start. And from there we go to a complete evaluation, which through our medical records now is so complete and so great that we will, on a separate visit, this is never done during an eye exam. You know, it's always done, we diagnose during the eye exam, then we bring you back to do an ocular surface disease evaluation, which is really a dry eye evaluation. And we'll go through all these different programs as I'm going to show you here. But the first thing we're going to do is, this is called a tear lab. And this is a piece of equipment now we can measure the osmolarity of your tears. That means we can tell how many particulate matter is in your tears, because if you have a high osmolarity, generally you're having evaporation. If you have an evaporation, there's something going on. Next, we can look at your eyelids. We know that eyelids are the cause of the majority of dry eyes. And so we'll use different tools like this or like this to actually express your eyelids, determine, do you have meibomian gland disease, which is usually the #1 cause of dry eye. This is new stuff. The MGD process was brought into being over the last 5 years. And 10 years ago, we didn't even test for this. And now we actually have ways where we can actually take a probe and put a probe down into the gland to reopen that gland to start the dry eye process. Now, most everybody knows what these are, artificial tears. And I'll pick up any one of these and know that when if you're using an artificial tear, you probably have a dry eye. If you're wearing contact lenses, you probably have a dry eye at some point in your life, because contact lenses are one of the things that do cause a dry eye. But I can tell you, artificial tears by themselves do not treat dry eye. It's rare, extremely rare, that these drops by themselves would ever treat a dry eye. And what happens is then we move to another drug called Restasis. And again, this is not a commercial, but I can tell you on almost all of our dry eye patients that need to use these drops more than twice a day, we go ahead and write a prescription Restasis. Now, a lot of you are going to say, well, I tried that, it didn't work. The problem is not that you tried this by itself, and you didn't do the array of other things we have to add to this. That's number one. Number two, this drug has to be used for at least 3 to 4 months every day in order to take effect. We really don't look for changes from Restasis till 4 to 6 months later. And when we prescribe Restasis, it's usually for a year. And again, you may say that's very expensive. There are plenty of programs now that actually make Restasis no more expensive than just buying an artificial tear. A lot of times we'll use both together, but not too much anymore. The next thing we're going to do is make sure that we first treat the problem. And that takes one of these medications, and there's many, many more. I'm just going through a small education thing. And this is called Lotimex. This is an eye steroid. This is cortisone for the eye that actually breaks the inflammatory process. And we know that dry eye is an inflammatory process. And Restasis, as I showed you earlier, is an anti-inflammatory drug that's very slow to work and very weak. Lotemax is very strong, but there are side effects, so we have to watch it very carefully when we start this Lotemax. Now, next you may say, we'll see patients and that may be enough, not be enough. We have a drug, it's a very old drug, but now it's back and it's used all the time called Lacrocerts. And these are actually little pellets that you put in your eye in the morning or the evening, and they emit a tear all day. So when you take Lacrocerts and add it to Restasis, now for those people who have really dry eyes, we have a way for them to take care of their eyes with only using a drop twice a day rather than using a drop 4 to 6 times a day. Now when we do use an artificial tear, we generally like to use a non-preservative, because a lot of people don't understand the preservative in tears may contribute to your dry eye. Now those are all different medications that we use on a regular basis. The next thing is punctal plugs. For y'all that have never had one, you want to know, a punctal plug is a tiny little plug, and we'll show you some pictures, that's actually placed into the drainage system of the eye to stop the tears. But we never put a plug in a person's eye before we've treated them with all this for at least 2 months, because we know we want those tears clean. And if you have dirty tears and you're plugging them into the eye, you're generally going to probably cause more irritation, not less. So the first thing to do is treat the eye, get it better, and then we add the plugs. We also are now expressing, as I showed you earlier. This is called a masking expressor, and usually it takes 3 to 4 visits where we'll actually have to express your meibomian glands, and we're going to show you a little video to show you what that's like. And what that does is allow the meibomian glands to start working. But you will then go home, and we have many devices. I'm just showing you one where this is a hot pack. You will put on your eyes at night for about 10 or 15 minutes to loosen up the meibum in the meibomian glands, so that when you massage your eyes, now you're getting them working. We know that that process takes, again, another 3 to 6 months. Dry eye is a process. Now, when going through testing, a lot of people know and heard about what's called a Schirmer test. It's a tiny little piece of paper that we put into your eye to determine how dry your eyes are. The biggest issue is this test really relevant? Now, if you have Sjogren's or you have rheumatoid arthritis, you have a true dry eye, acne rosacea, we know that Schirmer is great. But if you have a very low-grade dry eye or just some scratchiness, chances are Schirmers do not work very well. In fact, I hold very little on our Schirmer test unless you're an extreme dry eye patient. One of the ultimate treatment devices is contact lenses, and I'm going to show you a lens here. This is a normal RGP lens that'll hold this, that you'll be able to see. And next to it is now a scleral lens. And as you can see, the size of that lens is larger than the average soft lenses. And this is absolutely a hard lens that you can see. It's hard. The ultimate treatment for dry eye. We only use that when all else fails. Then we fit in scleral lens. Now you have other corneal diseases like keratoconus. This has been a wonder drug. So we use the scleral lens at first line, because sometimes we don't have to use any of these medications when we put patients in a scleral lens. And that includes people with graft versus host disease, which is probably one of the most severe dry eyes we're going to deal with. Okay, Joe, if you would blink your eye. Now, as you can see, this is what the eye examination moves to as we're doing ocular surface disease. We actually have 3 different dyes. And again, this is nice and color. We'll have fun. We always pick 2. Not sure which one you're going to get, Joy. But we really want to dye the eye with different kind of dyes, because we watch the tears and how they work with the eye. We also like to look and see how the surface of the cornea is, and that's what these different tears do. They stain the cells of Joy's cornea so that we can actually determine which cells are dead, which one's dying, and actually what the dry eye is all about. It's a real simple process, and this is what starts the dry eye evaluation. We've been through drugs, we've been through instruments, been through devices. Next is vitamins. And we know today that there are vitamins made just for the dry eye patient that have this right mix of omega-3 and omega-6 and other nutrients that actually help the eye produce more tears. And again, that's the goal, is to produce tears and to stop the tears from evaporating. The next treatment item is so simple, and sometimes we don't think how important it is, but sunglasses. If you have a dry eye, you should be wearing sunglasses when you're outside. It protects your eye and it keeps your tears like a moisture chamber into the eye and less evaporation. We like you to use a wrap type lens with usually a thicker type temple, so it actually creates a barrier. The same thing with your regular glasses. We usually on dry patients want a glass with a little bit of wrap, so it actually adds a protection barrier for our dry patients. As you can see, a dry eye is a very complex disease process that's progressive, inflammatory, and it takes so much effort to make sure that the dry eye stops getting worse. Because if you have a dry eye at 40 and 50, it's going to be really bad when you're 70 or 80. We went through this entire array of drugs, instruments, devices, and of course, most importantly, the examination to determine what is your dry eye and what are we going to do about it. We didn't discuss contact lenses because that's another show, but remember, when you wear contact lenses, there's a massive amount of lenses that we can use to help with that dry eye also, whether it be daily wear or the solutions you use, because it's very important on contact lenses, the way you clean the lens, the type of lens you're using, how often you throw it away, and its relationship with the dry eye. I hope this review and this little lecture gave you a comprehensive view of what a dry eye is like. Remember, it starts with an eye examination, which then leads to an ocular surface disease or dry eye evaluation, and then a treatment process. And it usually takes 3 to 5 and sometimes 10 visits to really get the best system for you and your dry eye. Thank you very much, and I hope you have a great day.